Hi, everyone. Thanks for joining. As we're getting started and having folks roll into the webinar today, I'll just go over a few general details that essentially, as you're listening to the webinar and engaging in that conversation, please use the Q&A functionality to just add any questions that you have, because either I'll address the questions as they're coming in from the Q&A feature, or also make sure that they're sort of answered at the end or offline for anything that you have questions on. So basically, if there's anything that you're curious about, please feel free to use the Q&A bar that you would see on the webinar on your screen right now. And I'll also just sort of kick this off as a brief introduction. So my name is Kate DeRazio. I'm a Senior Principal Product Manager at Oracle Health. My focus is on Oracle Health Care Management. So I'll be speaking today about essentially sort of the intersection of technology and care management and some of the strategies for success in this area. Also, just to sort of go through a few general statements here, there's just a brief sort of disclaimer on sort of general safe harbor legalese. Feel free to take a look at this. This page will also be available for review afterwards in the playback. And we have one more slide here, just general disclaimer slide for you to be able to read through. This also is something that will be here at the end. If you're looking at the playback section, you can refer to some of the disclaimers that are here as well. Okay. So I'm going to start to kick this off. Again, just as a brief introduction, my name is Kate DeRazio, and I'll be walking through the content of this webinar today. In terms of what we're walking through for agenda, I'm going to start with basically walking through sort of care management all up and sort of where the role of technology plays and some of the key challenges within care management. Then I will break down the rest of the session, focusing on the first chunk about sort of how challenges in efficiency can be addressed by artificial intelligence with some key use cases and sort of a case study demo. And then I'll talk about sort of how the role of interoperability also plays into challenges that are in this space for care management relating to efficiency. And then we'll have a section at the end for sort of Q&A. But this is really meant to be sort of a conversational, engaging type of webinar. So please, feel free to be adding questions or things you want to discuss throughout the session today while I'm speaking to different parts, because I'll be checking the Q&A and I'll address questions as we're going through it. So don't feel like you need to wait until the end for questions. Feel free to add them while we're talking earlier on. So again, the first part that I want to sort of set the stage with is just talking about where we think the role of technology is within care management. And the way to start to think about that is to first address sort of what are the challenges within care management itself. So care management today, especially when we think about ambulatory care management, care managers who are dealing with patients with complex issues, complex chronic care issues, are burdened by a few factors, some of which have been sort of entrenched for many, many years, and some of which have also been accelerated or sort of put a bit under a microscope after the COVID-19 pandemic. So some of these issues involve heavy caseloads of having to be able to manage just a very, very large set of patients at one time for a given care manager. Relating to the pandemic, fatigue, which can also relate to job dissatisfaction. And also just sort of chronically, a lot of amount of time is spent on the care management side on sort of administrative tasks, manual tasks, and sort of preparation, paperwork. That's time that's not actually directly engaging with the patient, but sort of work around the work, engaging with the patient. And the impact of all these challenges is really overall less time that's being able to be spent interacting directly with patients. And these can cause, in addition to things like fatigue or job dissatisfaction, risks for readmission, emergency department visits, or a negative impact on patient outcomes. And with just the efficiency or sort of the ability for care managers to only see so many patients, less patients are just under care management all up. So From our perspective, if we're sort of thinking about these issues in the current state of care management, things like heavy caseloads, administrative burdens, these very, very high patient volumes that are just more than what the actual capacity is for a care manager. The goals for care management solutions is that we want care management solutions to be able to improve efficiencies for care management organizations. That can help with also reducing the total cost of care, maximizing ROI. And we really think that within this set of goals, the opportunity for technology to play a role in care management is to be leveraging new innovations like artificial intelligence and machine learning to be able to automate some of the manual steps within care management workflows today, really agnostic of where the original data source is. So before I jump into sort of some of the meatier parts of the webinar, I actually want to take a quick pause here and ask a couple poll questions. So you should be able to see soon a set of 2 poll questions. So feel free to answer both of those questions. This will sort of help to give me a little bit of a sense of where you guys are right now, and also what areas of what I'm about to walk through I can sort of dig a little bit more into based off of where your interests are and also sort of where your experience is right now. Okay, great. So in terms of just, what I'm seeing here for interest, there's interest in sort of generally understanding sort of the AI component of how AI can help with care management. So I'll focus in on there and also dig into some of the specific use case examples. That's great to understand. And sounds like there's sort of a bit of a leaning towards sort of a beginner background on AI. That also just helps me to understand sort of where we are. So that's good to know. And also sort of given that background, again, feel free to sort of add or sort of pepper in questions relating to those topic areas as I get to them. And I'll talk through those pieces as we're going through the rest of the agenda. So the first part where I'll focus some of the attention here is on sort of the role for AI to improve some of these care management efficiencies. And, AI is good at a lot of things, but there are some specific sort of thematic use cases where applying AI is most beneficial, the things that AI use cases are the best at. So AI is very good at doing things like surfacing insights, saving time, and I think like reducing manual steps, which is kind of reducing burnout. Like those are kind of the really good sweet spots for AI use cases. So for surfacing insights, some examples of sort of how that plays out within care management is being able to extract data from what we consider unstructured data, like documents, PDFs, things that may be scanned in as images for faxes that aren't just sort of in the system itself today, like your EMR system. AI is very good at basically being able to take in things that are considered, again, unstructured, sort of just like raw documents, for example, or voice messages and just, a random sort of string of text, and create some sort of structure or sort of extract the sort of latent details and insights from there that you can use alongside everything else that's already properly documented within an EMR system. In terms of surfacing insights, it's also very good with things like prioritization. So if you have, again, sort of these swaths of patient lists, to be able to have some meaning of prioritization according to a few different dimensions of really who's important to see across, again, factors that are more than just one particular risk score, taking in other things like social determinants of health or conditions, or again, other sort of data elements to recommend where the urgency might be. And then also for doing things like highlighting gaps in care. That's one sort of bucket area of, insights. You can basically think about AI for a lot of use cases where your core problem is around surfacing insights. Another one is saving time. So AI, especially using large language models, is great for if you're trying to do a task where you're collecting a lot of data or summarizing a lot of data from multiple sources. It's very good for being able to recommend or suggest next steps or action items based off of sort of what's being presented to it for some sort of raw input. And it's really good for that sort of first draft step for if you're drafting documentation, if you're drafting notes. where, there's sort of that writer's block syndrome that happens a lot of time. And like when a human takes that first task of just starting with like a blank piece of paper, writing something down is very good at sort of getting that first draft out. So then you can work off of something versus starting from zero. And then the third bucket is, burnout, which is essentially having to deal with a lot of repetitive manual steps. So a lot of things that are repetitive, that sort of are very routine, but there's maybe many sub steps are really good use cases where you can automate some of these with AI and have really sort of a core final step, like a review step be where actually, a subject matter expert who's a person would be stepping in for that. To sort of break this down a bit further in terms of like, aside from the general areas where AI is sort of good at helping for care management, if we think about this another way, we can think about this through sort of the core workflow for care management scenarios and care management and end-to-end activities. So kind of 4 general buckets for sort of how you have a care management workflow is identification and stratification, your patient onboarding, then your active care management, and your external communications. So what I mean by that is, identification, stratification is sort of finding the patients who need care management and basically categorizing them, bucketing them in terms of, urgency and risk. Then once you've identified those patients in need of care management services, onboarding them by basically reaching out for enrollment so that they enroll, registering them, and sort of getting all of those first assessments done to get a baseline with this patient. Then there's the bulk for active care management, which is basically who on your active case list are you seeing first or next? How do you prepare for a check-in with a care managed patient in terms of reviewing their chart and seeing what's happened since the last time you met with them? Documentation, follow-ups, basically creating notes from your conversations with the patients. And then external communications happen sort of across the board. A bulk of it is during active care management, which is where basically you're communicating with the rest of the care team to follow up on action items that you sort of have identified for your particular patient and doing things like referral management. So sort of across the board, across the spectrum of the workflow, there's specific use cases within care management that AI can help. So I'll just start to sort of give some examples for each step there. And again, if you have any questions as I'm walking through this, feel free to throw them in the Q&A. So the first section here is, you can use AI for ranking purposes to be able to determine from these large potential case lists who really the next best patient should be. Of really who, if I'm only able to have the capacity to onboard one more patient, who would that next patient on my case list be? In terms of onboarding, you can think about basically enhanced and personalized enrollment, where instead of just sort of either manually doing outreach to a given set of patients or sort of just using a general template that's being emailed, you can actually use AI to personalize that message that's being sent out to various patients that takes in a bit of the background information we know about the patients, maybe again, some of their social determinants of health information or information about their sort of known chronic conditions to make it a more compelling message and also to try to increase those rates of enrollment. In active care management, there's a huge set of use cases, but some are around the ideas of summarizing basically chart information to prepare for, meetings with existing patients, suggestions for next best actions, and being able to draft some of those summary notes that happen after calls have been made with given patients. And then similar idea for drafting also for external communications where, based off of some of the action items that may have been determined for a patient, having a first draft of what that message communication might be for the rest of the care team versus sort of spending all the time sort of typing out from scratch each time sort of what some of the coordination follow-ups might be with someone else on the care team for a given patient. So, these again sort of all up are, a swath of use cases specific to care management where you really could leverage various AI capabilities on, especially leveraging large language models or computer vision for document extraction, as well as sort of ranking systems to help with making each of these steps more efficient and also just being able to prioritize, again, more time for the care manager, being able to take that like tangible action with a patient or engaging with the patient versus searching, collecting, collating information, or doing sort of routine sort of manual tasks that get to sort of that are steps that take a while before the actual meaningful action happens. So then also, since a good number of respondents said that they're sort of newer to some of this AI space and want to understand some of the general ideas of how to leverage AI within care management, it's important to also keep in mind that you really want to make sure that you're grounding any type of adoption of an AI feature to basically success metrics. And the success metrics should be basically the same exact ones that you're thinking about for your entire care management organization all up. They really should be tying to really those same key tenets of areas like the increased percent of new patients that you're able to see more patients because of some sort of efficiency that the AI use case was able to develop. Or things like patient outcomes, so percent decrease in ED visits or percent decrease in patient admissions. This is basically that there's something about latent insights that were delivered or more care was able to be administered per given patient that helped to impact the actual patient outcome for those care managed patients. Or metrics that are relating to, again, a care manager organization's goals around ROI. So the decrease in the paid amounts for given patients that's seen in care management compared to those that are not seen by care management organizations, and the percent increase in ROI for care managed patients. So, no matter what sort of use case or sort of scenario you're looking for AI, before you even go down the path of trying to implement it, you should think about which of these sort of buckets of success metrics would this potentially ladder up to. And if there isn't really a specific one that seems like it would be related to it, it might not actually sort of impact your bottom line. And it might be worth sort of looking for a higher use case AI scenario. And then this is not an exhaustive list, but again, for those who are sort of newer to the space here and you're thinking about, hey, how could I potentially use certain AI capabilities that either I want to implement myself or I see from various vendors in my use case, what do I first want to pilot if I'm new here? This is not exhaustive, but this is sort of a bit of a set of considerations for if you're trying to pick the first one to sort of pilot or the first couple that you're trying to pilot. If you're newer in the space, like, again, you would want to start with something that's sort of like a lower risk, lower hanging fruit type of scenario here. And the ways to sort of choose something that's like a nice low risk scenario to begin with, and a good checklist for if you're engaging with, again, sort of thoughts on various use cases or conversations with vendors that have new capabilities is to think about some of these things here. So first, is this feature patient facing? Ideally to first start off with, it's worth sort of thinking about use cases that maybe can impact and help care managers, but aren't directly something that the end patient can see. Two, there's a lot of use cases where you're adding more information or sort of you're adding an efficiency for a use case, but it doesn't replace any existing information. So that's definitely ideal to start off with. It's also ideal to start with something that isn't like responsible for making any type of decision or diagnosis. Like there's many use cases around, again, summarizing information, drafting information, prioritizing information that aren't like an end decision. So again, if you're sort of newer to this space, it's worth choosing something that doesn't do that type of a decision. Also, is there some sort of human step? Is there a step where I, as a subject matter expert, as the care manager, get to review, validate, and I decide what the next thing is that will happen? That's always very important. And also, is there some way that I can validate this information or sort of validate that what's happening is correct? That's important to understand. In terms of sort of like the testing area here, say either if you're doing a pilot where you're trying to sort of test out the efficacy of a use case, or you're working with a vendor who said they've tested this and you have questions that you want to ask them, it would be, hey, like, do I have a diverse data set? Do I have a diverse set of use cases I'm testing this with? That's important. do I know what my testing criteria is? Like, you should establish that methodology before you start the pilot of like, what am I trying to optimize for here in terms of like the testing criteria? And do I have minimum targets of what I want to hit before I maybe roll this out to the rest of my organization? And then once you've rolled out your first pilot, things to think about is, hey, is there documentation on how this works? So that someone who's not a subject matter expert in AI, but who is the domain expert, like a care manager, can understand how to use this feature. Is there some sort of training session for these end users, which would be care managers? And is there a way for the end users, who again, ideally are again, someone on the care team, to give feedback on what they're seeing? So again, this is not an exhaustive set of criteria, but there are things to think about if you're starting to consider or you're curious about new technologies and how they can help with a given workflow in care management. And we're going to kind of like take one case study of this to sort of walk through an example of how this can work. And this is a check-in prep feature. So basically, when we think about first the problem statement that came from this use case, this was derived from research that we had done in terms of how much time was being spent by care managers preparing for check-ins with their patients in care management. So we were seeing a lot of manual steps that were being done to review and collate information from various workflow components. That was basically taking between 15 and 30 minutes, and in a good chunk of our respondents' feedback, more than 20% of them were spending 30 or more minutes reviewing information before they could actually talk and engage with the patient themselves. And when we talked a bit more with some of the end care management team, the things that they were reviewing each time that they were sort of manually pulling together to try to get a sense for what's happened to them since the last time they met were looking at chronic conditions, changes in medications, non-chronic conditions, notes from visits that happened since the last time they saw the patient, notable labs and vitals, and then also details like procedures and what are the future appointments that a patient would have. So sort of given that pain points, where again, what we're trying to sort of tackle here is efficiency and time saved, that also should be able to relate to, the percent of patients that a care manager could see all up in terms of target metric. We released on the Oracle Health care management side for our product line, a feature called check-in prep, which is basically, if you see in the blue box on the right-hand side of this screenshot, it's basically an additional sort of component modal that has a summary view of those various data elements that were sort of being spent manually sort of reading through by a care manager and putting it in one place that gives a summary of what's happened to a patient since that last check-in that they've had with the patient. And the goal here is, again, to reduce time spent on chart reviews and increase care management efficiencies. So that's sort of how we identified the use case. Again, trying to reduce manual steps, try to work on collating and summarizing information, overall with the idea of being able to increase the number of patients that a given care manager could see and reduce time spent on manual tasks. When we think about how we sort of picked this use case, again, screenshot is sort of how this looks with mock data, fake data on the box here. We introduced an incremental component. So it's basically a new modal, not replacing any data that was already existing before. So we didn't touch any of the existing workflow components that a care manager was used to. And there's no action associated with this. This is basically just providing a brief only for the care manager with additional sort of summarized information. There's no sort of next step that happens. With this tab here, it's really just as a reference for the care manager. And this next step that happens after this each time is that the care manager is about to speak directly with the patients. And this is not patient facing, it's just for the care managers within an organization. We also added in a feature called supporting facts, which is basically helps with validation of what you're seeing in the summary. That is, again, using large language models to summarize that information. So basically, when you click on the supporting facts button, you get this pop-up that basically gives for each data element the description of the data, the source of where that data element came from, and the date, so that it's very easy and straightforward for an end user to basically see where the information they're seeing in this AI generated summary comes from. And then this is an optional step that we have for end users, but there is basically sort of like a thumbs up, thumbs down type of button within the feature itself, so that end users can give feedback if they want to on the summaries themselves. And when we moved to actually rolling out this capability, we documented reference pages that were public. They're public for basically end users of this product. We basically rolled out a client training session as well, so that basically end users could see and understand how to sort of work through this step by step. And then sort of when you put that all together, when I sort of walk through sort of some of the use cases and the components there, the way that this sort of looks live with mock data. Again, this is just sort of it's just sort of a string of text for the summary, but in terms of how this actually works, to give you a bit of an idea, basically there's this sort of additional sort of pop-out tab. You click generate summary, and the summary knows the last date that you had your check-in. You click supporting facts, you can basically see that supporting fact. And then again, you can click sort of the X or the check button to give feedback. And this tab here is the new tab on the right-hand side. Doesn't replace anything, and it's also basically expandable and contractible. So, you know, if the care manager doesn't need to see this right now, they're not in this step of meeting with a patient, they can just minimize it if they want to. And then when they minimize it, this is the view that they would have typically seen in a normal day working in the system itself. So that's sort of how the feature sort of behaves from an end user perspective. It's very similar to what's already part of the existing system for clients who use this feature, just with this sort of additional set of information that's expandable, and again, with reference information and ability to give feedback. So then when we sort of look back at those key considerations I mentioned earlier, and think about that for what I just walked through, you can see how this feature sort of hits on all of those areas of considerations of not being patient-facing, not replacing existing information, having a human review step, which is that like a care manager can read the summary. There's a way to validate the data with supporting facts. This was something we also tested with a very diverse data set that we've published externally, where we had a testing methodology, and we actually published our targets for the quality metrics itself. We published documentation, had a training session, and we actually embedded a feature for feedback, in addition to our normal channels for where clients can give feedback on the product overall. So again, this is sort of a way you can sort of start in the journey of leveraging AI technologies to create efficiencies in a really sort of like helpful, scalable manner, that's controllable as well in terms of sort of how this may change or sort of impact some of the existing care management workflows. I'm going to skip over these two elements here in terms of some of the data that's actually in the summaries itself, unless there's questions or curiosities on that. But I will pause here for 1 second to see, for this use case and sort of some of the key considerations, are there any questions from the group in terms of what I've just walked through that I can quickly address? Any questions on how that feature works, or how that relates to some of the consideration areas that we were walking through earlier? So then I will move through for the next part of the agenda here, which is basically the idea of how we can also address some of the care management challenges with interoperability. So the first section, we're talking about how AI can help with this, then we'll talk about interoperability now. So the areas where interoperability can help with care management challenges, actually a lot of them mirror some of the ones that we actually walked through on the AI side, in terms of saving time and helping to reduce burnout. And it can also help with reducing errors. So if we think about where interoperability plays a role for reducing errors, it's basically the challenge that exists today with any end user or care manager who has to basically manually look between multiple systems to try to get that full view of a patient, it just makes it very difficult or likely that they're missing some sort of set of information because there isn't one 360 view about the patient that is important in some sort of decision or next step that they're making. So having siloed information always just increases the chance that something might get accidentally missed because there's a manual step that's required to be looking in each of those silos each time. And then again, because there is this sort of silo set of information, this relates to time spent because basically you're spending time collating, collecting that information, and sort of logging in and out of various applications to actually get the details that are needed for engaging and working with an existing patients. And sometimes too, communications between systems means that there's also some sort of like faxing step or something else to actually transmit information between two different entities that don't have that same operable system. And because of this, it takes extra time, but also it's taking time because there's a lot of manual steps. And because there's a lot of manual steps, that's where this relates to sort of the issues with burnout, because they're sort of mundane administrative tasks that aren't necessarily high value that, you know, are the things that are closely related to issues with fatigue and healthcare workers in general. So, you know, they're redundant and they're administrative. And this is an area where if, you know, those were not present, it would help with sort of reducing areas of the workflow that cause job fatigue. And now there is a limitation, or there are not necessarily as many sort of direct steps that like an end health organization can do to manage interoperability on their own. But there are things to be sort of thinking about for various vendors that you're working with, or there's still some general rules of thumb that could be considered when we think about how we can come up with interoperability solutions relating to care management. So when we think about the data silos themselves, one option is, again, just sort of reducing the number of sort of siloed vendors, or basically the number of vendors that don't have interoperable systems, because that means that the organization will then actually have to manually sort of stitch that together themselves. So the number of vendors that don't work together that are under one organization, the more interoperability challenges you're going to have. And sort of relating that to is basically looking for vendors who support some sort of multi-source, EMR agnostic type of data platform to help with reducing that data silo issue. In terms of sort of the issues with saving time relating to sort of communicating and sharing information between sort of different applications if they don't have that same interoperability, is thinking about vendors that can support intelligent communication. So, you know, ideal is sort of that vendors can offer information exchange across multiple systems, that there's sort of like a data source agnostic exchange system that's available from vendors. If for some reason that's not possible, like some of the workarounds that maybe could be interesting or sort of help with this pain points on the vendor side is, at least if there's some sort of intelligent drafting or follow-up capabilities, that at least the time spent, if there is a need for email communications between the broader care team due to these data silos, could be sped up as much as possible, or that there's intelligent text extraction from scanned documents if scanned documents still are sort of needed and inevitable with at least one of the systems that you're working with. The ideal is obviously to work with something that's completely interoperable, but sometimes you can't get around it. So maybe being able to just at least quickly extract information that's being sort of scanned or faxed in is one workaround that can be considered on the interoperability side. And then sort of, again, the ideal though is like looking for vendors who maybe also are offering more than one modality, more than one application experience that can help with either integrating data from multiple sources, so you have like one view that can plug into many sources, or again, some sort of other UX or modality that can sort of work alongside other applications as well, so that you can sort of have companion app style, you know, experiences where you can see the insights from one system sort of very easily while you're in the workflow of another system. So that's like another option to consider where, if even the systems aren't agnostic themselves, like, is there at least some sort of user experience that makes it feel like you can stay within one workflow while still getting the insights from another one. These are all some areas, all different areas of sort of how care management organizations can think about sort of tackling the problems relating to interoperability if there isn't sort of one like coherent vendor that they're working with at this point that is completely EMR agnostic. So with that section there on the interoperability side, I want to actually be able to pause now to see if there's questions from the group in terms of what we've talked about for sort of identifying AI use cases and sort of rolling out AI scenarios within care management, or thinking about the challenges within interoperability and how those can be addressed, or what to sort of consider when thinking about sort of solutions for care management and how they may impact interoperability. So if you have any questions, feel free to add them into the Q&A section of your screen on the webinar.
Kate, I have a question. It's Frank from Chime. I'm sorry for my technical problems getting in earlier, but as it relates to interoperability and AI, is AI making it more difficult to have interoperability because of the variances in language sets that AI uses? Or is it making it easier because AI can negotiate some of those normalizations itself and make it easier to use? I don't know if the question makes sense.
Yeah, I think that question makes sense. I mean, I would say, if anything, AI would be making interoperability easier because it can help with normalizing data. But the two are both critical pillars of each other, if it makes sense. So like an AI system is only as helpful as the data that's being sort of fed into it. So if you want something to summarize information, but you're only giving it one siloed bit of that information, it won't be as good as if it sees all the information to summarize off of. And then I guess on the other side too, interoperability relates to AI in the sense that, like, if you want to streamline sort of trying to connect between sort of siloed areas of information, AI can help with that in either sort of mediating sort of manuals, again, sort of scans or communications that still need to be sent between systems, or normalizing some of the unstructured information so that it could be sort of added to one of the sort of disconnected systems if there is some sort of non-EMR agnostic setup that an organization has. So if anything, it helps, but they're also still like in some ways, at least, interoperability is a dependency for AI to be as helpful as possible.
Okay, interesting. We've got another question here. What are some considerations for health organizations that would health organization that would want to build this in-house, homegrown?
So if a health organization is thinking about potentially building their own AI use case in-house, there's a few sort of buckets of scenarios they should be considering. So one is, do they have the expertise, like the technical expertise in-house to do this? Like, do they have data scientists staffed for this, in addition to, engineers, where it's not necessarily about just even making this use case, but a platform for testing and monitoring. These are sort of continual systems that you want to make sure that you are, I guess, you'd be having to create that framework yourself in-house. So are you staffed with the right domain experts for this? And are you willing to sort of build some of those foundational sort of MLOps platforms in-house for that? So if you only have one use case or a couple use cases, or if you don't really have the domain experts in-house, I think that would be a challenge or might not be worth it. That would be a reason to go sort of for a vendor provided option. And then also the thing to think about would be cost. So, if you're building in-house, you still would be paying costs for whatever sort of AI system or offering you're using. So especially if you're thinking about things for large language models, you would want to test with a POC, basically how expensive that is for if you're using it yourself. Because some of these technologies can be expensive on their own. Sometimes there's efficiencies with basically like you don't want to deal with certainly wouldn't want to deal with sort of hosting your own LLM yourself unless you have, again, a lot of use cases. And there is, in some of these scenarios, basically a cost efficiency for being sort of one user of another organization or vendor that has enough sort of end users across the board, sort of spread out that cost so that, again, you want to be ROI positive on adopting this AI use case. It should be helping sort of reduce the total cost of patients that are in care management or increase the number of patients that a care manager can see. So if it's costing money in the end to set up the infrastructure for this use case, it may not be worth it. It's worth running the numbers before sort of going down that path. So those would be the two areas to think about the most.
To what extent do you find that your clients have somewhat of a hybrid approach, disproportionate as it may be, but doing a little bit homegrown and a lot of you?
Are you saying if that is a good idea to take a hybrid approach? Is that what you
No, I'm
said?
just wondering how many, if you find that there are a lot of clients that do it that way, or is it mostly all or none?
I think it's kind of a maturity piece. I
Yeah.
think that pretty much uh, organizations that are earlier on in their adoption journey, like it makes a lot of sense for the reasons I mentioned to start off with leveraging sort of vendor provided offerings. And most will probably take a lot of vendor provided offerings until they run into a use case where they've become sort of mature enough that they know that they have a more niche use case, or maybe that they realize now after sort of understanding how to monitor, track the performance of various use cases, that they actually have some of this data in-house to maybe make one particular use case more performant. So it's kind of a case of AI maturity within an organization too, that when they're sort of later on in the adoption phase, they may realize they can peel off a use case or two that it makes sense for them to actually try to further optimize it in-house.
Understood. Okay.
Yep.
Here's a question that came in, which is sort of near and dear to my heart. It's not my question, but I love it. How has Oracle Health handled hallucinations in the development of their AI tests or tools?
Oh, that's a very good use case. I mean, or very good question. So a lot of that has to do with basically implementing, first of all, there's the use cases that you're choosing, of course, where you're sort of understanding where the edge cases for hallucinations could live. And then also to look at basically how are you validating the information that's available. So basically, if you're able to point to each data source and basically show where the reference of that information is, that helps to basically expose and eliminate the risk of something sort of hallucinated showing up, because you can see what the sort of citation or essentially sort of like the bibliography for that information where it resides. And also, it's not necessarily relating to specifically the check-in prep use case, but it just in general, taking use cases and implementing use cases that are grounded in specific concrete data, which is basically when you're using like a RAG model, which is essentially sort of leveraging search plus an LLM, where you're querying and grounding it on like a specific set of reference documents that you have, is a great way to also eliminate and reduce the risks for hallucinations versus just asking general questions using an LLM. So basically grounding it in some sort of documents that are part of a retrieval augmented generation system. This is going a little bit more into the technical details than maybe some of the group is aware of, but it's basically a pattern of using your core reference source of truth documents as what the system is referencing when it's providing some sort of answer or solution. And that's one technique that is highly recommended when you're sort of looking at use cases within care management.
Interesting. Another question, are you finding that prompt engineering is becoming more and more important in terms of the onboarding for the use of these systems?
Yes, I think that's one of the core, like prompt engineering and what I mentioned earlier for RAG are like two of the most sort of important techniques to be sort of considering when you look at most
Mhm.
of the use cases that are, the first ones to start off with when you're trying to do efficiencies with care management, where you're either you're trying to there's many different prompt engineering techniques, and a lot of them actually help to sort of refine the performance of that
Mhm.
system uh, really in a much more efficient way than having to go toward anything that's like fine tuning. So basically, before you have to do anything that's like fine tuned, you can actually usually use a very sort of well performance standardized large language model with a combination of prompts engineering and potentially a RAG system to get those high quality results.
Okay, thanks. Another question from the audience. Earlier in the presentation, you talked about success metrics when leveraging AI. Are there certain metrics that you're seeing, and especially new metrics that weren't there 2 years ago, that people are using that are noteworthy when building out the AI-based use cases?
So I would say still the success metrics they really should be tied to the organization's success metrics. And that's how you make sure that like your investments in AI use cases are going to be aligned with your investments in the business, that like it should be tied to some sort of end metric that you're already targeting for care management of,
Hmm.
increasing the number of patients seen, increasing basically patient outcomes, which is reducing, say, ED and inpatient visits, uh, looking at impacts of total cost of care for those in care management versus those not in care management, and increasing ROI. So
Hmm.
they are still the same, or they're still the standardized success metrics for care management. Um, there's metrics to sort of check the quality of a use case that are specific to the use case, but the success metric is still the same as the ones for care management all up.
Okay, interesting. You had mentioned burnout, which is always a big topic, no matter what you're talking about in healthcare right now. Are you finding that in the systems there are ways of tracking, I guess what's commonly known as pajama time, in terms of when people are actually using this and getting them away from having to spend time in terms of quality of life?
Not for these AI use cases specifically. I
Hmm.
mean, that's more about if there's things that are being implemented within any given system, just
Hmm.
the application itself, looking at like time spent in the system.
Hmm.
Um, so, in general, like implementing any type of AI-based efficiency will sort of help with
Hmm.
the contributors that sort of lead to that end result. But you don't necessarily need AI, or you're not looking at an AI use case for even just monitoring that. That can just be done sort of today within technologies if an organization is really interested in that.
Okay, thanks. The final question I have here is, where do you see the future of care management going if AI features are successfully adopted?
Yeah, so I mean, what what I see as a future for if a organization and multiple organizations are successful at adopting the ROI positive AI use cases for care management, is that essentially the sort of pie chart of a care manager's day today, um, you know, I would say in a lot of cases, too much of their pie of the time, if not the majority of it, is not time spent with the patient. It's all administrative tasks, documentation, or just coordination or like logistics with the care team, where maybe you're talking to someone else in the care team, but you're not actually, again, like directly like meeting with a patient or sort of getting that final result of it's just if the
Mhm.
result was scheduling an appointment, or the result was checking on if a medication was filled. Like that end result of confirming the medication was filled is the much smaller amount of time versus all the work that took to get sort of that final answer. So if AI systems are successful in care management workflows, you'd see the pie chart of a care manager's time spent directly engaging with patients being like, 90% of their day versus
Mhm.
like what could be, 10% of their day or 15% of the day. That would be what the future is that basically care managers and people who are subject matter experts in caring for patients actually get to spend the time with the patients, not the work around being with the patients.
Mhm.
And that these repetitive tasks or sort of just interim tasks of, again, sort of coordination, logistics, preparation, summary, all of those things, documentation, like everything except for sort of that final part that involves the subject matter expertise of the care manager can be sort of unburdened from them. And they're just being able to really just spend more time directly impacting patients.
Thank you. I don't see any further questions. Kate, any closing remarks?
No, crazy general remarks on my end, other than, I had a great time sort of walking through this content here. I hope that this sort of helps with sort of painting the picture of sort of two areas of technology that are really critical for sort of solving the challenges for care management today, and sort of the direction of where things can sort of go for the future of care management. And I hope that this was helpful and informative for the group. So thank you all.
I think it was powerful. I'd like to thank everyone on behalf of Chime Digital Health Insights and Oracle Health for joining us today. And we will have this up archived. And if you have any further questions, we'll have contact points where you get further information. Thank you all.
Thank you.